Hi, Jamisha. Hello.
Hello.
Yeah, so I do have um the link. I'm gonna send it to you now, private chat.
Okay, great. Okay.
Um, Here is a link. And hi, Tanisha. Good morning. Good afternoon.
Good morning, good afternoon, my time.
How are you?
I'm fine, thanks.
Good. Okay. So I do have Dr. Hoyle also here. I wanted the three of us to connect before we admit every other person. Did you
Okay.
get did you get the bio that I sent to you? You will be introducing her and I
Yes, I
will be
got that.
introducing you, and then we have a small program that we're gonna run through. So
Okay.
excited. So Dr. Hoyle, Tanisha was a Peer 360 fellow, an eminent one for that matter.
Oh,
She's almost wrapping up her doctorate in Canada.
congratulations on that for sure. And it's a pleasure to meet you.
Thank you. Nice to meet you too.
All right, so I'm going to go ahead and admit every other person. So if you guys, I'm gonna be on mute for a second. All right, good afternoon, everybody from Washington, D.C. I am so excited for today. This is actually one of my most exciting days in the program. I see everybody. So today is one day that we ask everyone to be on video. Take this time also to re-label your name in Zoom so that we know who is faculty, we know who is fellow, and I do hope that you guys are in your best of mood. Link, is so nice to see you despite everything. How is life? How is family?
Hi, my daughter's still in the hospital. It's been day 2.5 of being admitted. I'm actually gonna go see her right after this. So my husband took over for me today, so I can be here.
It's
But she's
incredible having you
yeah,
here,
she's
but let
getting
us know
better.
if you need to step out for any reason, please do let us know.
Thank you so much. I appreciate it.
All right. Thank you. So guys, I am Rami. I'm Dr. Rami Azuine. You all know me by now. I am the lead faculty here at the Global Health and Education Project in Washington, D.C. I work with an incredible group of faculty staff who really make this program work, and I am totally indebted to all of them for the work that they do. Today is a special day for all of you. We are going to be listening to the final projects that you do. You guys have really been on this journey for the last 3 months. And I'm sure you're going to tell people being in Peer 360 for 3 months is not a joke. It's more than a semester of work, because the discussions we have, the counseling we have, the anger that we have, in the school is different from what you have in regular university, where everybody pampers you. There is no pampering here because we want you to come out and be the best. So I'm gonna share something. I hope I'll be able to share that. Yes, yes, yes. Can you guys see my slides?
Yes.
Perfect. Okay, so it is December 2. It is the graduation ceremony. This is what we are going to do. We're going to have welcome and introductions by me. We're going to introduce the moderators, and then the PA 360 fellows are going to introduce themselves. And then we will have an introduction of our commencement speaker, Dr. Hoyle. I'm not going to say anything about her. I'm just going to leave my co-moderator to introduce her so that you can see the kind of person that is going to be talking to you today. Then after that speech, we're going to have a capstone presentation, the group one. Each group is going to have 20 minutes. So we expect, 15, 80 minutes, and then question and answer, and then the second group will go question and answer, and then the third group. So please, for our audience, for our fellows that are joining, feel free to use the chat function to ask questions, to add commendations, to say kudos, using the Zoom features that you have. Feel free. We want this to be really lively and engaging. Feel free to bring young people, feel free to bring family, feel free to bring kids. Public health is about the entire family and the entire population. So we are grateful. This is me. My journey to public health has been over 20 years across Africa, across Europe, in North America, at community level, at state level, at federal level, at international level. And I can tell you, I live and breathe public health. Public health is in my blood. I love public health. I know that my work has changed lives. I know my work has saved lives. I know that my work has contributed to the optimum development of children. I know my own children benefited from my work. And that is why I'm so passionate that we are here bringing and training eminently qualified next generation of public health practitioners. You're going to go and do us proud. The world is waiting for you. Here are the team that you have been working with for the last 3 months. You have seen Dr. Susan, who has been working here as our federal lead. Dr. Zubi has been working with you, Dr. Chidubem and Brown. I'm going to give them actually opportunity to introduce themselves rather quickly. So, Dr. Susan, and for each person introducing themselves, let us know where you are joining from. That makes this program exciting. While we're waiting for Dr. Susan, I'm going to go to Dr. Zubi.
Hi, everyone. Welcome to today's graduation. I'm really especially so excited to see how far you guys have gone and to come to this today. It's really a great joy to see each and every one of you grow from where you started from and to where you are now and where you are going. And when I saw different topics that you guys have been working on, I was super excited because they are so intriguing. And I'm so ready to listen to all you have to say today and to contribute to that. And Public Health 360, I am the program navigator. And most of you already know I've been communicating with you right from the start. And now you are towards the end of your graduation. Congratulations again. And today we are here to support you and we'll be here as a community to help you through your journey. Welcome, everyone. Thank you.
Dr. Zubi, where are you joining us from?
Yes.
I'm always excited. The globalization, yes.
I'm joining from Florida.
Fantastic. The Sunshine State. Okay, next, Mr. Brown Magnus Olivers. Brown. Is Brown there? Okay, Dr. CJ. Okay, I think they're gonna come on, hopefully. And then Dr. Susan.
Dr. Romy, can you hear me?
Yes, I can hear you now. Quick introduction, please. Yes.
Okay, thank you, Dr. Romy, and welcome everyone. My name is Dr. Suzanne Ekejuba. I'm one of the faculty here at Global Health and Education Projects. I'm the program director for our programs administered by Global Health and Education Projects, including PA360. I'm so excited to learn from all our participants today. I'm also excited to see them come through these 3 months or arduous 3 months. It's been hard. You have received a lot of training that will put you out there as a public health practitioner. You have been empowered. So I'm so excited to listen and learn from you today on public health programs. Thank you. I'm calling in from Riverdale in Maryland, USA. Thank you.
All right. Thank you so much, Dr. Susan. Now, moving on our agenda, the next is introduction of the moderators. All right. I'm gonna quickly escape. All right. I'm still sharing.
Yeah.
Stop sharing. Very good. Oh, perfect. Thank you. Thank you so much, Zubi, for pointing that out. I am so excited to be moderating today's event with a product of the Public Health 360 Fellowship. I have invited Ms. Tanisha Wright-Brown to join us from Canada as the co-moderator. You can see her. Tanisha, do you want to say hello before I introduce?
Hello, everyone. Congratulations on your achievements. Nice meeting you all.
All right. So I have a quick introduction. Tanisha is a planning and policy analyst in the Department of Health and Community Services with the government of Newfoundland and Labrador in Canada. She is also pursuing her PhD at Memorial University School of Pharmacy, where her main research interest centers on the cannabis retail market in Canada. Her work investigates the barriers and facilitators to operating a retail cannabis outlet in Canada, and whether the government's cannabis policies and goals are being met. In 2020, Ms. Wright-Brown completed a Master of Science in Medicine with specialization in applied health services research and a research focus on natural disaster resilience and empowerment. She holds a Bachelor of Science in Business Management, and she has over 16 years of combined professional experience in policy, research, finance, and logistics. And so I just want to add that when Tanisha was a PA 360 fellow, she was a great one at that matter. She, you know, when you have good students, they make the faculty work harder, right? They are asking those questions. They are asking you why this, why that, and we love the kind of students. So she went on, you know, right after that, got this job with the government. And since after that, she has referred students who have also gone on to get positions with the government in Canada. So we are really, truly, truly excited that she was able to spare time to come today. I know she just came back from another conference where she had 2 presentations there on her work, you know, but coming here, really joining us to see what you guys are learning is really great. Before I hand over to her to introduce our commencement speaker. Hey, come on, let's give Tanisha some love.
Thanks,
Right?
Dr. Romy.
Yes, let's give her some love. So before she does the formal introduction, I want to use this opportunity to welcome all our guests. You know, if you're here as a friend, if you're here as a family member, if you're here as someone even who heard about the program elsewhere, you are so welcomed. You know, we hope that you will learn something today about the program, about the interventions that these phenomenal fellows have proposed to, to work on across the world, and that you will remain in touch with us. The program, we know also there are a number of people who are watching live on YouTube because the program is broadcast live on YouTube. So we thank them also and give them shout out for those who are joining us on YouTube. So this is going to be incredible. So ladies and gentlemen, without much ado about nothing, I am pleased to request Tanisha to introduce our commencement speaker.
Thank you, Dr. Romy, for the opportunity to do this. This is my first time moderating or assisting in moderating, but I actually came here to experience this wonderful event. I know that when I was here, it was a pleasure. So I wanted to give back as much as I can. Dr. Jamisha, is that the correct pronunciation? Okay, so I'd like to introduce Dr. Jamisha Oil. She is a senior consultant and an infectious disease epidemiologist with over 18 years of experience in public health emergency management. She serves as an advisor to senior leaders of the U.S. Department of Homeland Security Office of Health Security, focus on capacity building with state, local, tribal, and territorial partners. Throughout her tenure as a federal government consultant, Dr. Hoyle has supported the management and administration of multiple multi-year contracts, grants, cooperative agreements, and technical directives to support the mission of various U.S. agencies. In addition to her responsibilities to execute large multi-year budgets, Dr. Hoyle is tasked with leading teams of SMEs to execute initiatives such as scientific research projects, policy reviews, and technical training in preparedness, response, and mitigation of all hazards. She has successfully managed multidisciplinary global teams of up to 700 people in the daily operations of the organizations. She is extremely skilled at coordinating and managing teams across several jurisdictions and/or countries with competing needs and priorities. Her success in several programs in her early days of the COVID-19 pandemic serves as the gold standard for organizations and has helped to successfully expand the program initiatives both domestically and internationally. Dr. Jamisha Hoyle is a 2022 Atlantic Council Millennium Leadership Fellow and a 2023 term member of the Council on Foreign Relations. She holds an MS in biohazardous threat agents and emerging infectious diseases from Georgetown University and an MPH from George Mason University and a DHSC from A.T. Still University. We welcome Dr. Oil, and I will ask her to speak now. Let's give her a hand, please.
Tanisha, thank you for the introduction, and thank you all for having me here today. So good day, good morning, good afternoon, good evening, depending on where you're joining us from. I would like to start by first congratulating each of you as fellows on completing your 3-month public health training program. with the Global Health and Education Project. Having gone through very similar programs myself, I know that it is no small feat and truly an accomplishment. As a long-term public health practitioner, it is both exciting as well as rewarding to see the commitment that you all have to the field of public health. Your contributions are needed now more than ever. As we're transitioning into a post-pandemic world, I invite you to really explore your own personal next steps. So when I started my own personal public health journey, my interests were keenly tied to infectious diseases, particularly the HIV/AIDS crisis throughout the continent of Africa. Through academic as well as professional training, I learned more about the threat of infectious diseases, not only to human health, but also with considerations for animal health and environmental health. I quickly started to notice that public health impacts every aspect of our lives. And just hearing Dr. Remy open with that, I think that was definitely likely solidified in your program over the last 3 months. Now, when you think about your own journey over the last 3 months, what have you truly learned? Maybe you've noticed the need to provide programming for underserved communities, or perhaps you've noticed that climate change is having a devastating impact on food security. Perhaps you noticed that instability due to global migration has increased the public health concerns worldwide. Or maybe, it's not simple at all, you've noticed that we just need to have stronger partnerships. I hope more than anything, you have noticed and noted the need for transformation and the power of your own voice. As a public health professor, I always challenge my students to consider the cultural components of public health and the health inequities that people experience. A simple switch to a community-based approach, which strives to really understand the underlying causes, the social determinants of health, could vastly change the health outcomes of communities. From your program, you likely had discussions on the impacts of laws and policies to community health, and perhaps how maybe things like housing and food access can impact people on a more individual level. As a society, we are behind on the metrics of the World Health Organization's Sustainable Development Goals. We've all been ravished by the impacts and the effects of the COVID-19 pandemic, and we continue to experience inequities in issues such as maternal and child health and immunization programs worldwide, in some cases having the ability to eradicate disease or minimize the threat from disease for vaccine preventable diseases. We see growing concerns and issues in HIV, growing issues with tuberculosis programs or malaria treatment programs. We see how nutrition is impacted not only by food security, but also by climate change. Consider your own countries and countries around the world, and what does healthcare access look like? It varies truly from country to country. And we all know that a disease threat anywhere in the world is truly a disease threat everywhere in the world. We see the constant rise of non-communicable diseases, and we know that environmental health is becoming more and more important, whether it be from the effects of climate change or the introducing of emerging or re-emerging diseases. According to the World Health Organization Director General, Dr. Tedros, we know that the ability to direct services to those who need them the most is vital to advancing health equity. And health equity, in my personal opinion, is one of the largest issues that we have in public health. So as your program concludes and you move forward in your careers in public health, I want you to remember that a career in public health is a career of service. It is incumbent on each of you to remember the people that you represent and to make use of the knowledge that you gain from this program to change lives, not only in your own family, but also in your own communities and your own countries. So knowing this, I want to leave you with somewhat of a call to action. First, the power of speaking up. I can remember very early in my career being quite intimidated to provide my own perspective, generally out of something that may have been imposter syndrome or challenging my own knowledge and not necessarily thinking it compared to others in the room, but always knowing that I had a unique perspective. So those instances were telling me that my own experiences were not valid, but they were. They were valid then, and they are valid today. And in every room, I think it is imperative that you speak up. Share your experiences, share your perspective, share your ideas. It is in hearing from each of you that we will continue to strengthen the field of public health and encourage better outcomes for our communities. Next, as Gandhi would say, I'm going to encourage you all to continue to be the change that you want to see. You likely entered this program 3 months ago with some idea of how you wanted to use this program, this information, and maybe along the way, you've learned something that you never even imagined that you would learn. Now that you are empowered with this information, how will you empower others? It's incumbent upon you to share. Empower those around you. Look for opportunities to include women and children in public health discussions. Always ask yourself, who else should be here? Who should be making decisions? Who should be part of the planning process? How can we gain additional information from the communities to truly make community evidence-based decisions? And then continue to make an impact in ways of striving to cultivate those relationships. And then lastly, I encourage you to stay connected. There is strength in numbers, and the GHEP has built a strong alumni network. I encourage you to stay not only connected with each other, but also to continue to pour into the cohorts that will come behind you. So you've heard 2 people today on the call who are products of the program. They not only continue to pour into the field of public health, but they're back here to be able to pour into you. And the future cohorts will be just as thankful and just as grateful for you coming back to share your experiences as well. Remember, it is a career of service. The interconnected relationships that you've built here will likely be the same relationships that will help you continue to grow as public health practitioners and continue to make a global impact that you committed to when you submitted your application months ago. In closing, I'd like to commend the staff of the GHEP program, an organization based in Riverdale Park, Maryland, for not only the local impact, but also the global impact in investing in the field of public health. And for you, the fellows, the graduates, it is a pleasure to be here with you today to not only see your growth, but most importantly, to call you my colleague and bind together in the wide-ranging commitments to the health of the public. Thank you, and again, congratulations.
It's powerful. Thank you so much. Please, may I ask you to unmute and let us give Dr. Hoyle a resounding applause. You can use everything. This is... Dr. Hoyle, thank you so much. On behalf of faculty, I do really want to thank you sincerely for your incredible words. I know how difficult it is to get you. I know how long it took us to get you. Not because we are anything different, just because You are an incredible person in public health, acknowledged globally for your service. We couldn't be more grateful for any other commencement speaker but you for today. So we want to thank you. We want to be really appreciative of all your support. And you know, I was taking notes for myself, right? Public health is a career of service, right? And is an immense career, is an immense opportunity to be at the front of trying to save lives and populations. So really, really grateful for the opportunity. So now we are going to actually open up for the fellows to introduce themselves. The fellows are going to introduce themselves and tell us where they are joining from, so that when they start their presentations, they will just mention their names and move on to the presentation. So I am going to be calling people according to how I see them on my screen. So guys, everybody be ready. You just have like 1 minute to introduce yourself, right? And that will include telling us where you are joining from, right? You know, who you are, what you do, where you're joining from, and what is that special passion for public health that you think drew you here. So who has the fortune of being the number one on my screen? And Zoom keeps scrambling people. All right, then the first one is Rose Munyoki. Rose, unmute and introduce yourself, please.
Hi everyone. My name is Rose Munyoki. I'm joining you from Kenya, and currently I'm involved in the evaluation of HIV and AIDS and non-communicable diseases interventions, which are implemented at the workplace. And what drew me to the Global Health and Education Projects program is to make a difference, be involved in making a difference through effective public health programs and also integrating research to improve the health of the population. Thank you.
Thank you so much, Rose. I have Ling Batoon.
Hello, everybody. My name is Ling Batoon. I am from San Diego, California. I am a genomic researcher by profession. I am a Master of Public Health student at Capella University, and I hold a bachelor's degree in clinical laboratory science from National University in the United States. What drew me to public health is, you know, I want to help underserved communities. I want to help you know, underserved populations, especially immigrants that come here and, you know, try to get the opportunities they need. So thank you for having me.
Thank you so much, Ling. Next, Harneet Sandhu.
Hello, everyone. My name is Harneet Sandhu. I'm joining from Richland, Washington. I'm a master's in public health student at Eastern Washington University. I hold a bachelor's degree in dentistry from Maharishi Markandeeshwar University in India. In brief, I will say that what drove me to public health is my passion to reduce maternal depression in women. Thank you.
Thank you so much, Harneet. Chinonso Ebere.
Okay, hi everyone. My name is Chinonso Ebere. I'm a doctor by profession. I'm joining from Nigeria. I'm the program director for evaluation and monitoring in I'm the program director for evaluation and monitoring. What drew my passion to public health is my passion for maternal and child mortality rate to help reduce the rate here in my state.
Thank you, Dr. Berry. Next, we have Romashka Shahi.
Hi everyone, my name is Serhiy. I'm from Ukraine. I am a doctor by profession with training in business administration. And what drew me to public health is, I believe, my passion to contribute in achieving universal health coverage in Ukraine. That's why I'm here.
Thank you so much, Dr. Romashkar. Next, Karishma.
Hi everyone, my name is Karishma Pandho. I joined you all from California. I am an MPH student at Eastern Washington University in the United States. I also hold a bachelor's degree in dental sciences from Maharishi Markandeeshwar University in India. One thing which drew me to public health is my passion to increase oral health access for underserved communities globally. Thank you.
Thank you so much, Karishma. Next, we have Bhagvi Kannan.
Hi, everybody. My name is Bhargavi Kannan. I'm an attorney by profession. I hold a master's degree in law from Pennsylvania State University and a bachelor's degree from School of Excellence in Law, India. Currently, I'm a public health fellow at Global Health and Education Projects. What drew me to public health is my passion to reduce homelessness and improve the lives of people. I came here with no knowledge of public health, and I can say for sure that I'm going out with an increased knowledge of what public health is, and I hope to pursue a profession in this. Thank you.
Thank you so much, Bhagvi. Next, Oluwatomi Olufade. Tommy.
Hello, everyone. My name is Oluwatomi Olufade. I'm joining from Birmingham in the United Kingdom. Currently, I work as a healthcare assistant in the mental health sector. I have a master's degree in public health. My passion for public health, what drew me to public health is my passion to improve the sexual and reproductive health of young people, specifically targeting teenage pregnancy. Thank you.
Thank you so much, Tommy. Next, Martina Widera.
Hello, everyone. I'm joining you today from Chicago, Illinois, in the United States. I have been a registered nurse for the past 10 years, and I'm currently finishing up my master's in public health at Chamberlain University. What drew me to public health is my passion for improving the quality of mental health care here in the United States. I want to address it from a systemic level, because I think we need a lot of changes and improvements in that sector of healthcare. Thank you.
Thank you so much, Martina. Next, we have Willa Gotling.
Hi, everyone. My name is Willa Getling, and I'm joining from Seattle, Washington. I'm a programs manager and educator by profession, and I hold a degree in medical anthropology and global health from the University of Washington. One of the things that drew me to public health is my passion for reducing the impacts of climate change on vulnerable populations. Thank you.
Thank you so much, Willa. Next, we have Amina McCrary.
Hi, everyone. My name's Amina McCrary. I am a patient safety coordinator by profession. I hold a bachelor's degree from Daemen University in New York. I'm in pursuit of a master's degree from Capella University. What drew me to public health was the desire to improve the lives of military members. As a current military member, I noticed that we have a lot of disparities that we should work on, and I hope that I can be a part of that team to help that out and be a driving force for those persons and within this family. Again, thank you for today, and I'm excited to learn more from everyone.
Thank you so much, Amina, for your service. The last but not the least, I have Eza Masood. Eza.
Thank you, Dr. Samad. Hi, everyone. My name is Azhar Masood, and I'm joining you guys from here from Lahore, Pakistan. I'm a health information manager by profession. So I stumbled upon public health through my ID endeavors, and I landed into public health field. It actually grew me, it actually gave me a passion to, since I work in interoperability, I wanted to make sure that we can enhance the accessibility of healthcare to remote areas. This is why I've joined this group as well. So I look forward to connecting with you all. Thank you so much.
All right, that is all our fellows. I know I did not miss anybody. So please, ladies and gentlemen, join me and let us give them a resounding hand of applause. This is great. All right. Okay, now the big deal starts. I am going to make sure that everybody can share. And I would like to give the virtual microphone over to group number 1. You have 20 minutes in total, and we're going to be really strict. You know, in PA 360, we are very, very strict. Dr. Rami is not usually very nice. He is not nice, you know, because I want you to be the best. So, group number 1, over to you.
Hello, everyone. Let me just get my slides prepared. Perfect. Okay. All right. Let's do this. Hello, everyone. We are Group 1. Welcome to Bridging Bites. Our grant proposal is to address food insecurity in Presidio County, Texas, in the United States of America. Our Bridging Bites program will be led by a team of visionaries. We from Global Health and Education Projects. To start off, my name is Ling Batoon. I am the program director.
Hi, everyone. I'm Bhargavi Kannan again. I'm the Director of Outreach and Communications. I'm joining from Austin, Texas.
Hello again. My name is Martina Wadera, and I'm the Director of Strategic Partnerships for the program.
Hello, everyone. I'm Doris Ebere. I'm the Program Director for Monitoring and Evaluation.
Hi, everyone. My name is Caroline Fay, and I'm the Director of Technology Platforms and Development.
Perfect. So our executive summary, Bridging Bites proposes a focused initiative to combat the pressing issue of food insecurity in Presidio County, Texas, with particular attention to its impact on children. In contrast to its high poverty rate, many families in the county face significant challenges in accessing adequate and nutritious food. The USDA defines food insecurity as a condition of limited or uncertain access to food, which can lead to compromised food quality and intake, particularly affecting the growth and development of children. This initiative aims to provide essential services to an underserved population with a special focus on enhancing the quality of life and educational outcomes for children in Presidio County. We are seeking funding support for these objectives, aspiring to establish a scalable and repeatable model for other communities that is facing similar challenges. For today's agenda, we will be covering several topics throughout our presentation. Now, the problem statement. In Presidio County, Texas, the profound impact of food insecurity is evident in its extensive consequences, extending beyond mere hunger to affect children's development, adults' health and productivity, and just the overall well-being of the community. The food insecurity crisis is characterized by both a scarcity of food, a lack of access to nutrition and affordable options, demands urgent, comprehensive, and sustainable solutions that tackle both its immediate effects and underlying causes, thereby ensuring the physical, mental, and economic stability of our community members. Now, Martina will discuss the types of food insecurities.
Thank you, Ling. So let's talk about how we define food insecurity. Households that report 3 or more conditions that indicate food insecurity are classified as food insecure. They were at times unable to acquire adequate food for 1 or more household members because they had insufficient money or other resources for food. Households having very low food insecurity were food insecure to the extent that eating patterns of 1 or more household members were disrupted and their food intake reduced at least some of the time during the year because they could not afford enough food. Next slide, please. In the United States last year, about 12.8% of households were food insecure at least some time throughout the year. Next slide. Texas has a second highest rate of food insecurity in the United States at about 13.7%. Presidio County in Texas has a food insecurity rate of 24.5% due to multiple factors, including long distances between residents and grocery stores. Next slide, please. So our target population for Bridging Bites are the children of Presidio County, Texas. Since 33.9% of this county's population lives below the poverty line, and the largest demographic living in poverty are males ages 6 to 11 years old and females 6 to 11 years old. Roughly about 530 children in Presidio County suffer from food insecurity. It is estimated that only 6% of food insecure people meet SNAP eligibility in Presidio County, and 18% of children are ineligible for federal nutrition programs. Next slide, please. So the demographic of Presidio County is majority Hispanic, with 43% of residents born outside of the United States. Among residents, the prevalence of diabetes is at 20.5%, and the prevalence of obesity is 45%. And now I'm going to hand it over to Bhagavi to discuss the purpose of our program.
Thank you, Martina. So hi, everybody. I will be discussing the goals, objectives, and the action plan of our program. So let's start. The purpose of the Bridging Bites program is to educate and create awareness on food insecurity issues in Presidio County. Specifically, the program seeks to decrease food insecurity by increasing people's access to eat nutritious food, thereby promoting long-term health. Next slide, please. So the goal of the Bridging Bites program is to improve food insecurity by increasing the number of food pantries in Presidio County. This program will also identify schools that are interested to educate on food programs and shape such programs in schools. So what are the benefits of this program? This will benefit the children in 3 ways. First, awareness on food security is created at school level. Secondly, there will be reduced distance between residents and food pantries, leading to better access. This has been identified as a great problem because the distance between people and their access to food is really high. So this will reduce the distance. Thirdly, reducing unemployment by employing more people at food pantries, thus improving economic security. Next slide, please. So our action plan will focus on 3 factors that drive food insecurity. First is improve the knowledge of resources available to the people. Second is to improve access to community resources like federal nutrition programs and also strengthen the food network. And thirdly, by creating economic security. Next slide, please. So we've identified the issue. We have certain goals, objectives. So who are the levers of change? How can we affect this change positively? So we've identified 3 groups that are the levers of change. One is the individuals. The individuals in Presidio County themselves are the assets that will meaningfully affect change. Second is the systems. And third are policies that including regulatory, local, state, and federal that will have considerable consequences. Next slide, please. So how will we achieve the set goals and objectives? There are 3 methods that we have adopted. First is learning. We plan to learn from families in Presidio County to understand the existing utilization of resources and areas of deficiency. Next, we plan to engage the community, especially families with children and youth volunteers that can choose to volunteer with nonprofits that are working to eliminate food insecurity. We plan to encourage donation to these organizations, spreading awareness about food insecurity on social media, petitioning to the local body for funding the food pantries, or just by promoting the organizations working to solve the issue. Lastly, we plan to increase access by mapping out outreach and enrollment support that already exists and also fill the gaps in areas that need some work. Next, please. So how exactly are we going to carry out this project? First, we plan to set up a mobile food pantry in Presidio, which will create employment opportunities. We've identified certain hubs for our mobile food pantry, as you can see in the slide, and we plan to operate this mobile food pantry on certain days and times in various locations that have been listed here. Secondly, we also plan to connect the dots on food insecurity by issuing a monthly newsletter with information on the area's health resources and nutrition topics written by volunteer health providers. Over to Martina. Thank you.
Thank you, Bhargavi. So now that we discuss that, we will talk about partnerships that we will be working with. So addressing food insecurity is a complex issue that requires a multifaceted approach. Therefore, establishing strong partnerships is essential to mitigating food insecurity. We want to begin by working with the local government to determine whether residents are eligible for any food assistance programs such as TAN, SNAP, or WIC. We also want to partner with the local school district to offer additional grab-and-go meals for the children. Also, partnering with the West Texas Food Bank can provide immediate assistance to families through our mobile food pantries. Places of worship can foster a sense of solidarity and support among community members and can be utilized as local food hubs for food drives and exchange programs, which is why we will partner with the West Texas Ministry. Hospital grounds at Presidio Medical Center can assist in hosting food drives to increase accessibility for the residents. Also, partnering with local retailers like Walmart and Dollar General can increase food donations and decrease food waste through retail rescue of any products with minor damage or issues. Next slide, please. So the short-term outcomes of Bridging Bites are to increase WIC and SNAP utilization for eligible families, feed more children through increased participation in school meal programs, and to increase health food access for children by improving healthy food procurement in local food pantries. Midterm outcomes are to increase food donations and increase access to food pantries by working with partners to reduce food waste. And ultimately, the long-term outcome of Bridging Bites is to eliminate food insecurity among children residing in Presidio County. And now Doris will talk to you about how we will monitor and evaluate our program.
Okay, thank you, Martina. For the monitoring and evaluation plan for Bridging Bites, the purpose of this evaluation is to assess the effectiveness and impact of the campaign in achieving its objectives, which include educating and creating awareness of food insecurity, increase access to nutritious food, reducing distances to food access points, and reducing unemployment. Bridging Bites will adopt the qualitative and quantitative approach to evaluate and monitor food insecurity in Presidio County, targeting mostly the children. Here are the steps we will take. We will conduct a need assessment test where we will start with gathering of data on the current state of food insecurity in Presidio County using a survey method of evaluation. A pre and post survey questionnaires will be distributed among children who can read and write, their parents and individuals in the community. This is to assess their knowledge on food insecurity. And for us to get the accurate data, the questionnaires will be in two forms, that of Spanish and English individuals, and the questionnaires will be of a yes or no answer. This will also help. Then we'll also conduct interviews and have discussions with focus groups, family members, community leaders, school officials, and healthcare providers. This will help to assess the causes and extent of food insecurity among children in Presidio County. Data will be collected to measure the identified indicators. To achieve this, the data will be collected from school free meals programs, noting the quantity, quality, and number of meals served to students, as well as the variety of options available. Data will also be collected from healthcare providers who monitors and document patient growth and development, as well as their records of medical histories. This is essential for evaluating the effectiveness of interventions and identifying areas of improvement. The data collected will be analyzed to identify trends, patterns, and gaps in access to nutritious food for children in Presidio County. We will engage or involve our stakeholders from the beginning of the monitoring and evaluation process to ensure their input in the design and planning, planning and goal setting stages. This will promote and enhance the credibility of the evaluation. Next slide, please. Here are the measurable output and outcome indicators with regards to Bridging Bright objectives. Our first objective is to educate and create awareness on food insecurity issues. And output indicators is the number of awareness carried out, the number of awareness programs that will be carried out, and the community engagement. The outcome indicators are increase in knowledge and behavioral change. The second objective is to increase access to nutritious food. And the output indicator is the number of new food access points and diversity of food offerings. And the outcome indicators is improved dietary habits and health metrics. The third objective is to reduce distances to food access points. The output indicator is mapping out
All right, it looks like we are having technical difficulties with Dr. Bere. Can someone take over?
Yes, I can take over. So for
Someone mute Doris.
The outcome indicator is transportation accessibility. And finally, the last objective is to reduce unemployment.
Okay, so I'm just going to go over objective number 4. So objective number 4, it's to reduce unemployment. The output indicator, it's a number of jobs created, and 2, community employment rate. The outcome indicator is economic impact and community well-being. So this is our 5-year projected timeline for our program. As you can see here, this is the expected actions for each year, starting at research and preparation to sustainability and project maturation. And now Caroline will discuss the dissemination of information.
We have 5 minutes.
Sounds good. Thank you, Ling. So when discussing the dissemination of information, it's important to ask the classic who, what, when, where, why, how questions. So we'll start with who. Who are the stakeholders who hold some stake in the Bridging Bites project? Of course, policymakers. The eventual goal of the Bridging Bites project is to influence policy so that nutritious food can be more accessible for these underserved populations. The second is food insecure households, children specifically, like Martina talked about. The third is the education system. Educators and schools in Presidio County will be heavily influenced by, the targeting of children as the underserved population. Next is health institutions. Having nutritious food be more accessible will have a very deep impact on community health outcomes. Next is local grocers. Other grocery stores and food pantries will be less overrun by people coming from further out. And there's now the provision of more accessible both brick and mortar and mobile spaces. This will generate new jobs. We'll hopefully partner with some local farmers because agriculture is just a very big sector in the local economy. And then all of this will stimulate the local economy, which is good for Presidio County. And then lastly, there are implications for nearby counties if the Bridging Bites project has positive outcomes. Next slide, please. So when it comes to informing the public, I've listed all 4 of our objectives and kind of pulled out the more measurable ones that Doris talked about. And For these objectives, data will be collected quarterly to evaluate kind of how the Bridging Bites project is working, or what needs to be altered. And this data will be in the form of surveys, as mentioned before, both at the mobile location and brick and mortar location, and hopefully we'll be able to provide some incentive for customers completing that survey. Next, using that data that will collect the surveys, a quarterly progress presentation will be made. It'll be made available on the website and on flyers that can be given out at public spaces throughout Presidio County. And also reports will be disseminated through healthcare, transportation, educational institutions for a more community-based approach. And we'll set up social media so that the location of the mobile food pantry will be made known at all times. Also, kind of having locations is sort of an advertisement in itself. If people walk by and they're interested, that gets word out, and word of mouth will be kind of especially effective here. Some limitations and concerns to take into account during the dissemination of information is that Presidio County has a lot of Spanish-speaking people, so how can we make bilingual resources? And then also technology access and social media involvement. Is technology accessible to everyone in Presidio County? And how many people are actually on social media? And this is a diagram of kind of where the information will be taken from: healthcare institutions, GPS and transit data, economic and employment reports, groceries and food pantries. That will all inform kind of how the Bridging Bites program morphs to the community's needs. And then the green bubbles represent where information will be disseminated, like placement in hospitals, having physicians talk to their patients about this, partnering with local small businesses, having a website with an updated dashboard from the survey data, and then also social media. And I'm going to hand it on over to Bhargavi to talk about budget.
Thanks, Caroline. So the estimated budget for the mobile food pantry is $120,000. And as you can see, the direct and indirect cost breakup in this chart, we've come up with $120,000 for this mobile food pantry. Over to Ling to conclude.
Thank you. So in conclusion, this grant proposal aims to significantly reduce and eventually eradicate food insecurity in Presidio County, Texas, through a well-researched and community-informed comprehensive plan. Collaboration with government agencies, local organizations, and private funders is crucial. The requested grant will fund these initiatives, contributing to a future free from food insecurity with Presidio County. This investment promises not just immediate relief, but also long-term community health and resilience. We appreciate your consideration of our proposal and your dedication to overcoming food insecurity. Your support is vital in realizing a future of food security for everyone in Presidio County. Thank you, everybody, for listening in.
Thank you so much, Group 1. This is on point, 1:05, exactly the time, because you guys felt I was going to cut you guys off. But this is great. Please join me. Let us give them a resounding hand of applause. This is well done. Well done. And again, we can take 1 or 2 questions. The summary of this project is that they are asking for $120,000 US. And for that amount, they plan to establish a food pantry, a location-based food pantry, as well as a mobile food pantry in an area that has huge food insecurity, a county called Presidio County in Texas in the United States. So 120,000 food pantry, location-based, mobile-based, and then the opportunity to offer employment and nutrition education. Any questions? I have question number 1. Somebody text me directly. And Tanisha, if anybody texts you, please let me know. So the first question is this. They said, how many people are you guys planning to serve? Like in month 1, month 2, month 3, how many people do you think this project is going to serve in 1 year? Who wants to take that? Any of you can take it. Program director.
Hi, sorry, I was on mute. Once we launched this program, since Presidio County is a very small county, I mean, like the population is, I think it was like what, less than, I don't know, Martina, if you want to chime in, but I feel like within the
So
first,
over 6,000
Yeah.
for total population for Presidio County.
yeah, I feel like within the first year we can reach, I honestly want to say 30 to 50%, because it's just it's a small county, and I feel like doing pop-up local pantries, it's accessible, doing the traveling thing like what Bhargavi introduced, to you guys. I feel like it's doable. It's very, very doable. Instead of, them coming to the local food pantry, we're going out in areas where it's so like, sparse and spaced out. So giving the opportunity for people to see like, hey, we're in your area, or we're going to the elementary schools, or we're here, I think our outreach would be really effective.
Good. I have a question from Dr. Hoyle and then from Tanisha. Dr. Hoyle.
Thank you. I think that was a phenomenal presentation. I really appreciate the multi-pronged approach that you had, where you thought about not only meeting people where they are, getting information from the local community, but also some of the things like how can we think about adding jobs to the community. One of the things that I always like to think about in any projects that I start is sustainability, thinking about sustainability first. As you have a 5-year program, and we know that not only Presidio County, the location has seen a huge influx due to mass migration, but we also know that the impacts of food insecurity will continue to increase. So whereas you may have a certain percentage of the population now that is impacted by food insecurity, that will likely increase over time. So what are some of the metrics that you're taking, especially considerations for some of the out years 3, 4, and 5, to ensure sustainability of your program? And then also beyond year 5, what would you like to see implemented in the local community? Thank you.
Thank you. That's
Go ahead.
Okay. That's an excellent question. So we're starting the program out as a pilot for a year and to see how it does. And then depending on our evaluation of it, we're going to basically, we really want to strengthen the partnerships that we have to continue sustaining the program. I think that's going to be really imperative to keeping it sustainable, is just making sure that our partners are going to continue to work with us. And then, if the population does increase and the need increases, then we can meet those needs of that population. We might also look at once we establish some solid partnerships, I think we would look at, potentially branching out to some other areas as well to kind of help us out if the need does increase, which it probably will, like you mentioned, because of the migration.
Tanisha.
Okay, quickly, thanks again, guys. Wonderful presentation. So my question is, how do you plan on determining the eligibility of those who benefit from your program?
Group 1.
So can I take this?
Go ahead.
Right. So the target population is children because of the severe, the low income families they come from. But this food pantry is an open food pantry wherein we would not have any restrictions on who can come and access it. It is open to all. It's a food box program, and it's open to all. And we would not have any form of ID checking or limitations on who can access this pantry. So we have a lot of budget allocated for this. $120,000 is a lot for the mobile food pantry. So we would be able to sustain ourselves in the long run, and also be able to meet everybody in that county, every person's need in that county. So we have no restrictions on who can access it. It's free, and it's free for all.
Very good. And there is a response there also from Amina, who suggested to the group to consider allowing the metrics from the surveys to determine if they are missing their target goals. So that is where it goes into that process, into that short term, into that midterm and long-term evaluation. And like Dr. Hoyle and Tanisha pointed out, sustainability is the number one, right? You don't want to have 120,000, you just start off the program, you build a community around your food pantry only for it to disappear after 5 years. Then you end up doing actually more disservice to the people, and another way could also be, how can you really begin to train some of the participants in the program using community gardens? Using home-based gardens, using containerized farming, where they can even begin to provide themselves with those food should this program go away. But once again, I think this is really fantastic program. I love it. If you are interested, in learning more about how this program can be implemented, please reach out to GHEP.info@Global Health Projects, and we will assemble the team to support the execution of that program. So group 1, nice job. Thank you so much. All right, next group, the indefatigable group number 2 is going to come on, right? Go ahead, Kanisha, introduce them.
Okay, so now we'll have group number 2 who will be speaking on maternal mortality in the USA. We want to welcome you all.
Thank you.
Hi everyone. Let me just put up the slides. Just give me 1 minute. I'll need your guys' help to confirm if this looks good.
Yeah. It's not full screen. We can see tab at the top of your browser.
I think it's good.
If it can be worked with, I'm having some trouble.
I think this is good. You can present with this. This is good.
Okay. All right, Krishma, can you let's start take over from here, and I will work on changing the slides for you. Thank you.
Hello, everyone. Today we are here to share the culmination of our capstone project, YANA, You Are Not Alone. As Public Health 360 Fellows with the Global Health and Education Projects, we have dedicated our efforts to address a critical issue, maternal mortality among Black women in the United States. Next slide, please. My name is Dr. Karishma Pando. I am one of the Public Health 360 Fellows serving as a lead and program director of YANA. Today, I'm delighted to be joined by my other PH 360 Fellows. Sergey, can you introduce yourself?
Thank you, Krishma. My name is Sergey Romashko. I am from Ukraine, as you already told, and within this team, I'm holding the position of Monitoring and Evaluation Officer. Over to Tommy.
Hello, everyone. My name is Oluwatomi Olufade. I'm joining from the UK. For the YANA program, I am the Director of Strategic Partnerships. Over to you, Azan.
Thank you so much, Tommy. Hi, everyone. This is Azad Masood, and in this project, I am the Director, Outreach and Communication. I look forward to this presentation. Back to you, Krishma.
Thank you, Azhar. Next slide, please. We will be talking about the purpose statement, problem statement, theory of change, evaluation, budget, and the conclusion in this project. To start with, the purpose of YANA is to reduce the prevalence of maternal mortality among Black women in the United States. Just a second. Next slide, please. The purpose of YANA is reducing maternal mortality among Black women in the United States, and our target population is Black women in Mississippi, United States. Recognizing the profound influence of the social determinants of health, we are committed to raising awareness to empower individuals and knowledge that can lead to informed decisions about maternal health. Our purpose of YANA is clear. We aim to make a tangible impact on the prevalence of maternal mortality by honing in on the unique challenges faced by Black women. I'm handing over to Tommy now to talk about the problem statement and goals and objectives of our program.
Thank you, Karishma. I'll be talking on the problem statement, which is maternal mortality. According to WHO, maternal mortality or maternal death, as it is also called, is defined as the death of a woman while she is pregnant or within 42 days at the end of pregnancy. And according to various sources, there are direct and indirect causes of maternal mortality. Some of the direct causes include excessive blood loss, infection in the blood, high blood pressure, unsafe abortion, and obstructed labor. And we also have some indirect causes of maternal mortality, which includes anemia or heart disease. Across the United States and globally, maternal mortality is considered to be an important indicator of maternal health, even today. Maternal death not only impacts families and communities, it also has a great impact globally. According to CDC, around 50,000 US women experience pregnancy complications annually. And alarmingly, Black women bear a high burden. It's said that they are at least 3 times more likely to die from pregnancy-related causes than their white counterparts. Black women face a reality of increased risk and limited access to adequate maternal health care, which has led to an increase in maternal mortality. In 2021, the maternal mortality rate for Black women was 69.9 deaths per 100,000 live births. And this is in contrast to the rate for white women, which was 2.6 times higher than that, which is 2.6 higher than that for the white women, which was 26.6 per 100,000 live births. Black women have the highest mortality rate of any racial or ethnic group, and this has been since 2014. This just highlights a high gap and a concerning reality that maternal mortality among Black women will continue to be on the rise if interventions are not put in place to reduce its prevalence. Next slide, please. According to data by CDC, Mississippi has the highest maternal mortality rate in the United States with 82 deaths per 100,000 births, followed by New Mexico, which is 79.5 deaths per 100,000 births. And California has the lowest rate, which is 9.7 deaths per 100,000 live births. And it is because of this high mortality rate in Mississippi that we have chosen the state. According to the Mississippi Maternal Mortality Review Committee in 2020, they found out that there were 48 pregnancy-associated deaths, of which 31% of those were directly related to pregnancy. And some of this, the top 5 contributing and underlying causes of these pregnancy-related deaths were cardiovascular-related, cardiomyopathy, pulmonary and amniotic fluid, sepsis, and other forms of infections. Even with the concerning rise in maternal mortality rate, 2/3 of this 700 of these pregnancy-related deaths are said to be preventable, but it's still on the rise. Next slide, please. 36% of Mississippi residents identify as Black, but 3 times, which is 3 times the national average. And around half of the state counties are considered to be maternal care deserts. So maternal care deserts are said to be those counties where they have a lack of maternity care resources, where there are either no hospitals or birth centers that offer obstetric care, or they do not have obstetric providers. Mississippi State is said to be one of the states that has this maternal care desert. Also, Mississippi State has one of the most strict bans on abortion, which means there are more forced births more term births and preterm births. And that is also one of the reasons why we have chosen Mississippi as our target state. Next slide, please. I'm going to go on to the goals and objectives of the program. The first goal is to raise awareness on maternal mortality among Black women. And our action plan is conducting webinars to raise awareness on maternal mortality and thereafter conduct maternal health education workshops for Black women. Our second goal is to decrease prevalence of maternal mortality in Black women, and our action plan is to establish partnership with Black community organizations and healthcare providers in the state. They have a good number of community organizations who target Black women in regards to maternal health. And also promote early screening and diagnosis will be with the health care providers. There have been some healthcare providers who focus on educating the women on early screening and early diagnosis. Our second action plan will be to facilitate interventions to increase accessibility to effective and quality maternal health care. I'm going to hand over to my colleague Asa for the methodology section.
Hi, Jamie. Thank you so much for giving us the outline of the project and the root cause and our goal. Now let's look into, so we discussed we have goals about how we're gonna raise awareness, but also we are going to prevent mortality, right? So to work into this, our project, it has a core of 2 main programs that we will be starting, and which will also go around with other programs that will be running on the sidelines. So the core of our program itself is that we will raise awareness and of the program itself. And we will do that by distributing a few flyers. We will do some online advertisement. We will also offer free webinars and surveys. We need to do this to understand the need of the people. We will use surveys and we will use webinars to raise awareness and get people to register actually for our second main program, which is the workshop itself. So initially we will go for the raising the awareness, and then we will move over to the workshop. Now, workshop itself would consist of 3 phases. The phase 1 of the workshop is again a seminar where we will discuss on the most pressing factors that are there in the community today for maternal health. So we will discuss on the nutrition and hygiene and the best practice around them. We'll also discuss on the contraceptive education. As Tommy mentioned before, this is really important because Missouri is one of those states which recently banned abortion. Without being political, what we need to make sure is that we are at least giving them contraceptive education, since we know it has the highest rate of deaths in United States. Moving over to, we did an outreach recently about postpartum depression. So we will continue using postpartum depression and we will continue to raise awareness about it through this program as well. All right. Now, the second part of the workshop, the second phase of it would be to provide training and to the people, right? So so we are going to discuss a few strategies that we are going to be covering during each of these workshops through trained trainers, right? So we will have professional trainers who will be giving out these workshops and healthcare professionals on the coping strategies of due to lack of access to healthcare or due to any mental health issues, and what are the best practices as well. We will also have some fun activities, do some practical demonstrations, distribute some educational pamphlets, and share some video resources that people can refer to. Lastly, this is actually the main goal of our program itself. In each workshop, we will have a traveling provider or a nurse or a midwife with us. So we will have at least one person with us during each workshop. And at the end of the workshop, we will offer, since we have already got the people through surveys, we have targeted the right people, we will make sure that we have a doctor who would be available to these, available for free consultation to people who are attending those workshops. And we will also make sure that, so we'll give the free workshop basically. Moving on to the next slide. Okay, so that is like our main goal of each workshop, but to make it happen, we'll need to build relationship with the community, the local communities that are based in these desert areas that Tommy mentioned. So for example, we would need some Black community centers that are already there. One of the examples that we were looking at were the Black Women on the Round Table. I might be getting the wrong name. I can definitely share that detail with you later. And we also have to partner up with healthcare organizations to identify providers or healthcare workers who would be willing to volunteer or work with us on a discounted price. Then we will take over the cost for the participants who are in our workshop. Now, we will also leverage the communities that we will be connecting with to further raise the awareness through distributing pamphlets and to getting people to register for our workshops. And finally, if the project goes good, we also have further plan to connect with underdeserved communities. For example, we will provide the online assistance or the phone assistance. So offering free consultation will automatically lead to early intervention during these workshops, and in effect also reducing maternal mortality in Missouri. Now over to you, Karishma, to discuss a little more about the model of our methodology itself.
Thank you, Azhar. We also use the socio-ecological model as a theory of change, which helped us understand the various factors that impact maternal mortality rates among Black women in the maternal care deserts of Mississippi. So our program aimed to address these factors at multiple levels by raising awareness about maternal mortality, offering free checkups, establishing partnerships and community centers and maternal health care clinics. Next slide, please. So the timeline of our project, the entire program will take 14 months, including the evaluation. So 4 months of the health outreach and pre-evaluation knowledge, 6 months of the maternal mortality health education workshops, and 4 months for post-evaluation knowledge analysis and the follow-ups. Next slide, please. So here we are with the project outcomes. So we'll raise awareness about maternal mortality and its risk factors among Black women in maternal care deserts of Mississippi and encourage them to participate in the workshops for free checkups. Conduct at least 16 webinars reaching at least 10,000 people online. Conduct 5 workshops annually to offer 100 free checkups in a year. Establish partnership with 3 community centers and at least 4 maternal health care clinics. And also provide who will offer volunteer or YANA-funded checkups to participants during these workshops. Now I'll hand over to Sergey for discussing evaluation plans.
Thank you, Krishma. To evaluate the effectiveness of our YANA project, we propose the following plan. We will get our targets achieved. This will help us determine if we are on track to meet our goals or if we need to adjust our strategy. We will collect and use data to evaluate if our project implementation goes effectively or we need some areas to be improved. We will assess the extent to which the project has been successful in reducing the prevalence of maternal mortality in Mississippi at the end. Slide, please. We will assess cost effectiveness. We will evaluate the cost effectiveness of the project by comparing the cost of implementation and the benefits and the results outcomes we did achieve. And last but not the least, continuous improvement. During the whole life cycle of the project, we will collect indicator, we will collect feedback, we will evaluate our work, and when and if needed, readjust our strategies to be more effective, to be more goal-oriented, and to achieve our targets. Slide, please. Yet another dissemination. Thank you. We will use a few approaches in parallel to disseminate achievements of our project to reach our target population, to bring information to them. We will use online platforms, utilize social media, websites, and online forums to reach a broader audience. We will use community offline workshops to achieve target audience in person. We will make media collaboration, partnering with local media outlets for broader coverage of population, and we will engage healthcare networks. We will work with the local providers to distribute program awareness through them as well. Slide. Here you can see distribution of roles in the team. I won't repeat the names and roles of beautiful team you already met. Also, we will have operations and finance manager who is not in the team currently, but will be engaged, and trainer and educator for some part-time activities. Slide, please. Budget. We foresee to spend roughly $98,000 spending, focusing on spending to outreach through different channels. So we will spend a lot to digital and to physical to distribution of physical materials, and also we will spend a lot to trainer and health staff fees who will help fees of people who will help us to distribute this, and we will have 10% of indirect expenses within this project. And over again to Grishma.
Thank you, Sergey. Concluding our proposal, as we envision the outcomes of our efforts of YANA, it's not just about achieving isolated goals. It's also about the broader impact on maternal mortality rates among Black women. By successfully increasing awareness and implementing targeted interventions, we anticipate a substantial reduction in the overall mortality rate. This isn't just a theoretical aspiration, it's a tangible step towards saving lives and creating a healthier future for Black women, mothers. Our approach is designed to bring about lasting changes and make a real difference in the maternal health outcomes, as we cannot do this without your support and funding. So please join us in this journey. Thank you.
Oh, well done, guys. Excellent presentation. I have a 2 congratulations in the chat. I love the program branding, Yana. Good job, guys. That's Chatachi. And Martina says, great initiative given that the US lags behind other developed nations in mother and child mortality. Okay, so Amina has 2 questions for you guys. One is, how will you attract school districts that do not teach sexual education?
All right, I can answer that. So our target here, even though it starts from 15 years, but our initial focus is on the mostly on the through the community-based approach, since we will be doing the surveys and we will be doing it online and raising awareness. But we definitely do have plans to do partnerships with the schools. But initially, that is not our goal. But down the line, once we have the success, we will look into more options on how we can get those schools who are not too pro teaching the sexual education. We will we will add that into the plan later, but that is not part of the plan right now.
Okay, thank you. Our next question is, due to the yearly weather conditions impacting areas of the state in cities like Biloxi and Gulfport, will members of the program be able to support already pregnant members of the community?
Yes, that is correct. Because our program, we will be conducting, so we have a goal to conduct at least 5 to 7, right? So we have to conduct at least 5 to 7 workshops in 1 year. And during this year, we will be initially targeting people, and we cannot definitely take weather into the condition, right? Weather conditions into as a factor before we make a visit. But our goal is to make sure that we reach there and we are there and the providers are there on the workshops, and people who need access will be able to visit those workshops within those desert areas, and they don't have to travel around. And hopefully that answers your question. Please elaborate more if that is not right.
Tanisha, Dr. Hoyle has a question. If we can take that as the last question, please.
Okay, no problem. Go ahead, Dr. Hoyle.
And thank you all for that great presentation, as well as actually for a very timely public health issue. So I have a couple of things I want you to consider, and then I'll just leave with one question that I'd like for you to answer. I think the thing that I want you to consider is very much related to the last question that was asked, and particularly how in some of your workshops that you're focused on webinars. So I think the webinar the goal was to reach about 10,000 people. A lot of this has to do with understanding the local population and what may and may not work. Very much Mississippi is a very rural country or state for most intents and purposes. And there's a huge digital divide where people don't have access to high-speed internet. So the likelihood of being able to join a webinar, especially with such pertinent information, I wonder how much of your population that you would lose or miss. So I would encourage you to think about the impact that you want to make and the outcomes that you want people to receive from your workshops. Would it be better in certain communities to have more in-person interactions? And how could you bring in and have a more impactful session by involving potentially someone locally who has experienced the horrible impacts of maternal mortality in that particular community? So how you could capitalize on that. The other thing I want to talk about, and I'll ask you a question, is that your program seems to be very much focused on pregnant persons, so those who can become pregnant. But have you thought about the need for establishing partnerships and allies in the community? So thinking about men who can support other people in the community who can support, but also you talked about your partnerships with the healthcare setting, which is very important because the healthcare setting is where a lot especially from the perspective of a Black woman, a lot of the issues start, right? Not feeling comfortable in the system, not having access to insurance, so you're not getting the best of care. So I would like to ask you, in your program, with your workshops and others, how can you ensure that you have a prepared partner within the healthcare setting that wants to achieve the same outcomes that you want from your program, which is ultimately a reduction in maternal mortality amongst Black women? Thank you.
All right, thank you so much for that question and for bringing all 3 questions together as well. So yes, we will definitely have to build partnerships, not with just the communities that are operating locally, because that will help us reduce the internet divide that we have, right? And to moving on, of course, we want to, instead of having healthcare providers traveling with us from outside of the state or from faraway counties, we focus to identify the counties that are mostly as in a cluster of remote deserts, right? So we need to identify, so we target to identify the providers or the healthcare providers or locations where we have an available provider, and so that it will be easy for them to travel over the weekend and set up a day workshop. and where they will be offering the consultation as a traveling provider with us. So the focus would not be just to look out for providers and build partnerships, but we want to have more providers involved in it, more people involved in it. And that is why we want to choose the local providers who are the closest and build relationships with them. I hope that answers your question.
Thank you. Handing over to Dr. Romy.
Thank you so much. We're going to go straight to group number 3. Thank you all, to give them the opportunity to do their own presentation, but I think this is great. So group number 3.
Hello, everyone. My name is Amina McCrary, a Public Health 360 Fellow speaking from Virginia in the United States, and I'm the project manager for today's presentation. Today, we will be presenting Health in the Balance, Diabetes Prevention Program in Pakistan. It's our capstone project, and next we will meet our members.
Hello, everyone. My name is Harneet Sandhu. I'm joining in from Richland, Washington. I'm one of the PH 360 Fellows and also the clinical director for the program.
Hello, everyone. My name is Rose Munyoki. I'm joining in from Kenya and one of the Public Health 360 Fellows, and I'm the Director of Monitoring and Evaluation in this team. I'll hand over to Willa.
Willa, are you muted?
I'm so sorry. Thank you. Hi, everyone. My name is Willa. I'm joining from Seattle, Washington. I'm the Director of Outreach and Communications. I'm also a PH 360 Fellow, and I'm going to hand it back over to our Program Manager, Amina.
So for today's presentation, we will review the following topics. We went over our introductions, start defining what diabetes is, go over our purpose and problem statements, our target population, the methodology, some goals and objectives, our budget, dissemination plan, some of our projected outcomes, and also final remarks and references. So today I ask you, what is diabetes? Diabetes is a disease that affects how your body uses sugar from food for energy. As the body breaks down food into sugar, it's released into the bloodstream. The elevation of blood sugar causes the pancreas to release insulin, which is a hormone that controls our blood sugar. So when diabetes itself arises, when the insulin is produced, if it's not enough or if it's not used effectively, that's when you begin to have some of the issues. There's 3 different types of diabetes. There's type 1, type 2, and gestational. And diabetes 1 is usually an autoimmune reaction where there's a destruction of insulin made by the body. Type 2 arises when insulin produces not enough for the body or when it's not used effectively. And gestational generally occurs during pregnancy among women. If a person is considered pre-diabetic, their level of blood sugar is above 80 to 130 milligrams per DL before eating, and then it's less than 180 milligrams, generally 2 hours after a meal. Some common symptoms of diabetes include being thirsty, frequent urination, unexplained weight loss, fatigue, and blurred vision. Heart disease and loss of vision and kidney disease are also associated if you do have or become diabetic. Next, I will turn it over to Willa, who is our Director of Outreach and Communication.
Hi again. So our purpose statement, our project is called Health in the Balance, once again. So 30% of adults in Pakistan, which is roughly 33 million adults, are affected by diabetes. Pakistan has the highest prevalence of diabetes of any country globally. And Pakistan's Balochistan province has the highest number of pre-diabetes cases in the country. So the purpose of Health in the Balance is to decrease diabetes prevalence in Pakistan through increased diabetes screenings and through involving at-risk individuals in our diabetes education and awareness program, Health in the Balance, which we'll talk about in more depth soon. I'm going to turn it back over to Rose to talk about our problem statement.
So what is the problem? So as Willa has highlighted, Pakistan has the highest diabetes prevalence among all nations worldwide. And this is compared to India, which has a prevalence of 8.3%, Bangladeshi, which has a prevalence of 12.5%, and the USA, that has a prevalence of 13.6%. So currently, as well as highlighted, Pakistani has about 33 million people living with diabetes, and this number is estimated to increase to about 62 million by 2045. As also Willa has highlighted, among the 4 provinces in Pakistani, Balochistan has the highest prevalence of prediabetes and newly diagnosed diabetes cases, and this was based on a national diabetes survey. In other words, 1 in 4 adults has diabetes in Pakistani, and around 400,000 died due to diabetes. And this was based on an International Diabetes Federation report of 2021. The same report highlighted that the cost per person with diabetes in Pakistan is $80.1 US, and given that majority of people in Pakistan earn less than $3 daily, it just shows or indicates the challenges that people might face in terms of accessing the treatment, because most people tend to purchase this medication from privately owned pharmacies. And although the governments offer free medication, in most cases, this is limited to inpatients, and also you find that sometimes the insulin products are limited. A study conducted in Pakistani found out that awareness on diabetes mellitus, that's type 2, risk factors, management, and care was low. And so that is why it's important to raise awareness, because diabetes can lead to other health problems, as Amina has highlighted. And so enhanced preventive efforts helps to lower the risk of these conditions and helps to promote good health and well-being. So on the right, you can see this is a table. This has the comparative diabetes prevalence that tends to compare the prevalence with the populations that have different distributions. I think it's important to note that worldwide, more than 90% of the diabetes cases are actually type 2 diabetes, which is actually preventable. Next slide, please. So for this project, we will target individuals who are aged 18 years and above, living in Balochistan, located in the southwestern part of Pakistani. So why this population? So a study among teenagers in Pakistani found out that junk foods were very popular among this population and contributed to an increase in the BMI. A report by the International Diabetes Federation of 2021 estimated that by 2045, people between the ages of 20 all the way to 79 are going to experience increased prevalence of diabetes. So that is why it is important, and it shows that not only are the older people at risk, but also the younger also are. And so it's important to engage them in preventive efforts. So the population of Balochistan is around 15 million, and the literacy level is 46%, which is the lowest in the whole country. And yeah, so since the prevalence of newly diagnosed cases is higher in rural compared to urban areas in Balochistan, and the prevalence of prediabetes is higher in urban compared to rural areas, this project will target individuals living in both rural and urban areas, and we will target 2,000 eligible individuals, both for testing, for diabetes testing, as well as Health in the Balance project, which is an awareness program. So next, I'll hand over to Anit, who will discuss the methodology.
Okay, so I'm going to discuss the methodology for our program. So decrease the prevalence of type 2 diabetes in Pakistan through increased screening for pre-diabetes in Balochistan. We will work both in the city of Quetta and surrounding rural areas. To start, we will screen up to 3,000 individuals aged 18 plus with the help of our partner locations, which is Salim Medical Complex Hospital, Bolan University of Medical and Health Sciences, and ED Foundation with connections to Jamia Mosque in Quetta and Zirath. After screenings, 2,000 individuals who are at risk of diabetes will be invited to sign waivers of informed consent to participate in our diabetes and obesity prevention program, Health in the Balance. We will also ask all participants to fill out pre-evaluation knowledge surveys about their knowledge of diabetes, perceptions of healthy eating and exercise, as well as personal eating and exercise habits. Health in the Balance provides individuals with free remote education on healthy eating and accessible exercises to combat diabetes and related illnesses. Health in the Balance utilizes tools designed by USDA MyPlate and the WHO Active Exercise Program. It is modeled after the Pakistan Diabetes Prevention Program developed in 1990. The key components of the Pakistan Diabetes Prevention Program are diabetes prevention and awareness, policy planning and advocacy, and implementing diabetes care programs at the national levels. Health in the Balance differs in that it works at a more intimate community level. The entire program will take 1 year, 3 months for outreach, pre-evaluation knowledge, 6 months for blood glucose testing and concurrent Health in the Balance educational programming, and 3 months for post-evaluation knowledge, analysis, and necessary follow-ups. To ensure the accessibility for individuals who do not have internet in their homes, we will offer live Health in the Balance remote sessions at Salim Medical Complex and have included in our budget the cost of internet, a projector, and compensation for space to temporarily utilize facilities. To measure the effectiveness of the program, all participants will also be asked to fill out post-program knowledge evaluations. I will now review some goals and objectives for the program. Goal 1 is creating a comprehensive diabetes prevention program focusing on educating people about benefits of a healthy lifestyle. One of the objectives is collaborating with local health departments and community organizations to implement Health in the Balance, obesity, and diabetes prevention program. Objective 1B is increasing community members' access to Health in the Balance program by 5% within the first 6 months of nutritional workshop implementation. Goal 2 is partner with local community organizations to increase access to screening and insulin testing for early detection of diabetes. Increase pre-diabetes screening by 10% in the first 6 months of introducing the program, and also increase blood sugar testing by 10% in the first 6 months. Rose will now discuss our budget.
So for this project, we are requesting a grand total of $101,500 US. And here is a breakdown of the costs pertaining mainly to staffing and the personnel costs as well as material costs. So next I'll hand over to Willa to discuss dissemination.
So first, we'll promote diabetes screenings through informational presentations, partnerships with individuals located at our partner locations. So once again, that's Salim Medical Complex Hospital, Bolon University of Medical and Health Sciences, and the Eddie Foundation, which has relationships to Jamia mosques, including in Quetta and Ziyarat, where we will focus our efforts. Eddie Foundation, which was brought to our attention by Azar. Thank you, Azar. Also has relationships with different healthcare facilities around Balochistan. So in combination of Eddie Foundation, Bolon University, which has an average enrollment of about 1,500 students yearly, and Salim Medical Complex being the largest hospital in Quetta, our reach is quite substantial. As noted earlier, the literacy level in Balochistan is 46%. Because of this, we will conduct direct in-person outreach at our partner locations with the help of hired clinicians and health educators, as well as some flyering. Individuals who test positive for prediabetes will be invited to participate in remote Health in the Balance sessions, which can be accessed in person at Salim Medical Complex, as Harneet mentioned earlier, or from home if people have internet access from their homes. To gauge the success of the program, we will conduct pre- and post-program evaluations with 2,000 participants who are at risk of diabetes. And we'll do this through measuring changes around the knowledge of diabetes, perceptions of healthy eating and exercise, and personal habits around eating and exercise. So Amina will now discuss our projected outcomes.
Thank you, Willa. By having members of the community enroll into the Health in the Balance program, the aim is to at least have a 10% increase of members enrollment within the first 3 months. Now, as the program manager, I'm hoping our efforts will be effective, and then I can report it back to my other counterparts if you've seen the areas they spoke on today. By improving education efforts by 5%, I think this will help not only just the community, but some of the facility partnerships that we support, and it'll also help make them aware of diabetes and tests that are presently related to some of their common symptoms. As we progress through the program, an increase in identifying members that have diabetes from the pre and post surveys, hoping to be increased by 10% after the first 6-month mark of the program, just to ensure that we're hitting all the targets that we were aiming from the initial beginning of the program, maybe even midway, and then again at the 6-month mark. Additional feedback will help us tailor the program in case we are offered the ability to implement it further past the 1-year mark that we're aiming to start with. As we move forward into our final remarks, we can see here the points to be touched on earlier today. So again, we addressed what diabetes is, along with some of the common symptoms found. We reviewed the purpose of running the Health in the Balance program. We addressed the problem that Pakistan residents are facing specifically in, I don't want to pronounce it incorrectly, Balochistan, and the target population of people aged 18 and older. We also reviewed the program's methods from how long the program will run and how the Health in the Balance application will work, discuss some goals and objectives, provide a suggestive budgetary breakdown, express the dissemination efforts with both the local community levels, and share projected outcomes within our program. Following the slide is our references where information can come from, or where it came from rather, excuse me. If there are any additional questions, either myself or my teammates are here to answer your questions today. So we thank you for listening to our presentation.
Wow, this is amazing. Please join me. Let's congratulate this team. This is really pointed. You can see one theme across the 3 projects. Global Health in Action. There are fellows who are working on projects in other countries, intentionally made so that they can implement the skills that they gained in the program in terms of needs assessment, in terms of learning how to partner with local organizations, in terms of cultural humility, right? Knowing what it is exactly that they are going to do and how to engage people at the local programming. So this is intentional to put people where they are not very comfortable. If you're in the US and you're working on a US program, you'll love it because you know it. But if you're in the US and you're working in a program in Pakistan, then you up your game and vice versa. So this is great. I'm going to give Dr. Hoyle the first question, and then I have 2 other questions in chat. Dr. Hoyle, remarks and questions.
Some excellent presentation, obviously on a growing issue worldwide. Just the impacts of diabetes we know is tremendous, especially when you consider some of the productive life years. One of the things I noticed in your program is that it is slated to be a year-long program with about 3 months for finding participants and then about 3 months for a closeout, but there's 6 months of active engagement with your participants. Oftentimes when we have the lengthier programs, we worry about losing participants to attrition. What are some of the metrics or goals of your programs to ensure that your participants will start and end for the entirety of the program? Thank you.
I think through the efforts of our application, because the members of the group will most likely ping and make sure they're a part of the pre and post, I think we will do our best to follow up more regularly after the pre-survey throughout the program and even before they start the post. As Willa mentioned, due to one of the local facilities having such a common number of students coming yearly, it never hurts to have incoming students be aware that, hey, this is another opportunity to reach people. So once you're here, let's look into some of our survey questions to get you started. So if it's an area of interest or an area of need, we might be able to get people even prior to their arrival.
We're also, Health in the Balance is going to run concurrent to us doing diabetes testing. And part of the reason for that is we wanted people, after they did their testing for diabetes, a couple days later to be able to walk over to the health complex and take part in the educational program that we have, so that there's really quick and immediate movement from feeling the intensity of like, okay, this is what I'm at risk of in being pre-diabetic, and here's how I can immediately deal with it. So that's another, I guess, method that we've come up with.
Great. Okay, we have 2 other questions. One question is actually drawing upon local knowledge and expertise. They say that Balochistan, where this program is targeted to be implemented, is close to Afghanistan. And you know what that means. There is a lot of challenges. It's an unstable area, hard to reach, lowest internet access in the entire Pakistan, and a lot of security reasons. How do you plan to work with local authorities to overcome these issues?
One of the highlighted aspects that both Rose and Willa spoke of was having access to materials that does not require just internet access. So the ability of being mobile. So having a projector, having materials that are offline. I think by even providing a pre-brief, meaning a meeting before bigger meetings, of showing community partners or showing those that may be concerned of us stepping into different territories, different lands, different governments, to show that this is what we're presenting and it's at this level of comfortability, that by giving them a bird's eye view before we present it off and share and show them exactly what we're using, maybe that'll allow them to feel comfortable with us coming in to help support not just Pakistan, but some of the other neighboring countries.
Great. Okay. The next question here by Dr. Sahi: for detected cases which cannot be treated by diet or exercise, are you foreseeing a situation where you are establishing referral mechanisms?
Yeah, so that's part of the reason that why we're partnering with Saline Medical Complex, is so that we can directly refer people to services that have doctors within that complex that specialize in diabetes.
Great. And the final question here from Martina, right, is it might be more cost effective and more realistic to do prevention rather than curative. How are you anticipating integrating prevention into your programming?
So sorry if that was unclear. We're basically we are focused on prevention of diabetes. We're focusing on individuals who have pre-diabetes but aren't yet diabetic. So everything that we're doing is testing for people that have pre-diabetes and then doing an education program to prevent that from turning into diabetes.
Thanks for clarifying that. The final question is going to be by Dr. CJ, and then we're going to begin to wrap up the program. CJ.
Hi, everyone. My name is Dr. Chidubem, and I really enjoyed this diabetes presentation. It's a topic that is dear to my heart, and I would like to ask, I don't know if I missed it, but did you guys mention or showed what the distribution of the supermarkets and the kind of things they sell around is in the area where you intend to do this project on? If they sell more of, junk food, fried food, sometimes educating the patients without them accessing healthy food, do the program also have a way of addressing that? One, the first question, if you guys showed something that has to do with location of supermarkets or the food stores around and the type of food they sell, and also if your program would address have them having to access healthy food if that is not available.
So we didn't directly address any of the local food facilities or anything related to how to better access healthier food options, or even, the need of what local communities prefer versus going to like a mass place to serve. But there was a point where Rose had spoke of what a survey picked up about what was reported from the local population. Hence why we wanted to address that was their concern as well, that junk foods are what was more readily available than healthier options. But I think through some of the partnerships that both Rose was discussing, and even with Harneet's point of view of our methodology, maybe that's something we can cultivate within not just our project, but implement within our budget. I don't think that was something as a group that we considered, but I do think it would be best if we can maybe include that for, further implementation in our program.
And also in the Health in the Balance program that we designed, we do use the USDA MyPlate app that gives a lot of information about healthy eating options, and also the WHO Active Exercise program that gives information about being active and reducing your diabetes eventually.
Okay, good. Because thinking of things that will be a challenge to your program and how to address them, or to just talk about it, is very important. Thank you.
Thank you so much, CJ, for that question. Ladies and gentlemen, this has been a great 2 hours. I call it Research and Program Festival. I am so proud of you guys. The fellows, 3 months, these 3 months has been really phenomenal. And I hope, and I know that you are living stronger, better, more prepared. You do not remember the concept of equity, right? Which is central to this program. You were trained in this program to be able to identify and address inequities in public health. So I can count on the 14 of you that you are going to be equity champions. And remember, when you hear about equity, and we talked about this in the program, do not think that equity is only about Black or white, right? Within group inequities are so persistent, and some groups within a particular race are bearing those disproportionate burden. We are sending you out today into the community, or we are welcoming you also into the community of public health, so that you can collaboratively join hands in solving these programs, regardless of the public health setting that you are working in, whether you're working at the local level, at the global level, at the national level, or even at the county level. There is an opportunity for you to be that voice for equity. There is an opportunity for you to be that voice that actually makes people uncomfortable, because they recognize and they think about you, that you are going to be the equity champion for the organization. So I am so excited. I'm going to give my co-moderator, Tanisha, the opportunity to share parting words. And then, we are going to formally dismiss today. Tanisha.
Okay, thanks again, guys, for your wonderful presentation. I want to express my sincere appreciation to our distinguished guest, our guest speaker, Dr. Jamisha Hoyle, the dedicated faculty, and the inspiring cohorts of graduate students. Your insightful contribution and commitment to advancing public health have made this program a thriving community of learning and collaboration. As you embark on your respective journeys, may your passion for public health continue to drive positive change. Congratulations to each of you, and best wishes for the future filled with impactful endeavors in the field of public health. Congratulations, guys.
Thank you so much. Be in touch. Remember, we are going to have in 2024 our PIA 360 conference somewhere in Canada. Canada somewhere calls. Just be on the standby and do not be strangers. Congratulations. Have a wonderful day. God bless. And, looking forward to hearing the wonderful things that you guys are going to do in the field. Bye-bye.